Luga, Director of Health Services at NMS. Dr. Luga, before you came in, we were just talking about the universal health coverage and wondering what would it really take to achieve it. And we're also comparing it to the pilot counties, Isiolo, Machakos, Kisumu, and Nyeri. What went wrong there and what can be fixed going forward?
Thank you, Trevor, and good morning to all the viewers. Good morning to my senior, Mheshimiwa Dr. Nyikal, and my successor, Davji.
Yes.
So I think a lot have been said about UHC for the last since 2017. You know, when the president once announced in December of 2017 about UHC, and then there was a one-year pilot program that involved the 4 counties. But you know, the framework of the pilot and the framework of what has been rolled out is different. As you noted, the framework was more of input-based in terms of commodities, and that worked in some ways, but also I think there are lessons that were drawn or that were learned from that pilot. For example, you know, the counties were chosen based on certain characteristics, but if you look at places like Kisumu, for example, where we were looking at an infectious disease burdened county, then you realize that there were some unsustainability because people were coming to the facilities, and then the facilities, of course, were running out of commodities. It was more of an input-based framework. And the same, of course, with Nyeri and with Machakos. So I think it is important to look at, it's not that it didn't work, it is the lessons. And therefore, I think there was a change in terms of the UHC policy that has just been rolled out for 2030. And now you see the shift is towards insurance, so that then you can try and engage from a perspective of outputs. But it's not purely an output-based.
Yeah.
I think what you had talked about in terms of access, affordability, and standards, to be honest, I think there's been a lot of progress in terms of access, and access is in 2 parts. Access is in the actual facilities, and then there is access in the actual services. So you may have level 4, a level 5, a level 3, a level 2 hospital, but are the services available? So there are those 2 aspects to access. And just drawing from what has happened across the country, and specifically from where I speak here in Nairobi. For example, if you're looking at 3.1 million people who are residing in the informal settlements in Nairobi, we've greatly improved access. In fact, let me just tell you, in the year 2021, we saw 4 million patients. If you go back to the year 2020, 2019, 2018, 2017, Nairobi facilities have been seeing only 1 million patients. So you can see from 1 million to 4 million patients, there is actually more than 4 times the number of people. That already is proof in terms of access, because these people, where were they going before? Now they are coming to the facilities. If you're just looking at maternity care, for example, we've seen an improvement in utilization of delivery services in public facilities from 32% to 54%. Just in 1 year again. And these figures are there in the Kenya Health Information System, or what was previously called the KHIDS, or District Health Information System. These figures are there for anyone to look at. So if you're looking at access, you can clearly demonstrate that something has happened. And I believe that some other counties may also talk about the same. If you're looking at affordability, that is exactly what the president was emphasizing in terms of now paying for the indigents, because many families go bankrupt seeking care. And the other flip side of it is that healthcare is not free, actually. Healthcare must be funded. It's either tax funded or patient funded. And so you're just trying to lessen the burden of these families that go bankrupt trying to pay for care. So in terms of affordability, of course, there's the first 1 million people that the government has rolled out a program for 1 year to sort of pay for them. Like in Nairobi, we've paid for 66,000 families at a cost of 400 million, which these are people who have been ranked in a scale and found to be the poorest. Of course, we found that there were 326,000 people in Nairobi, but of course, because of budget limitations, you must start somewhere. So we started with the first 66,000, and you can see that is just 20% of the total number that we have to cover. But I think once a program has been rolled, there has to be concerted effort to coalesce all the resources. So, you know, there are a number of organizations, NGOs, there are CDFs, like the way our friends Washimiwas give, there are social funds that come from county governments. So all of this needs to be coalesced to now plug into that gap. So because the government has already done the first investment, so then now we need to rally, and including philanthropists, private sector, because a country has to develop wholesomely. I think the role of government is to do two things. One is to create the policy, and number two is to create the environment that enables people to also plug into that. And then the last thing that you talked about is the issue of standards. I think on that one, there still has to be a lot of work to be done in terms of value-based healthcare. You have to look at the regulatory framework and the regulatory standards, not just for healthcare workers, but also for standards for infrastructure, standards for services itself, because I think we still have a huge gap as far as standards for practice is concerned, you know. So how a neurosurgeon, even if you were to provide the neurosurgeon, provide them with all the equipment, provide them, you still have a huge gap as far as how a neurosurgeon would do, would practice in Kisumu versus how they would practice in Nairobi. So even that in itself, so it's not just about the number of healthcare workers, it's not just about the norms and the standards for HRH. But let me mention something about the issue about the healthcare workers, because I think that is, of course, where I have come from before, and that is still I think there's a bit of pain in terms of the weak link with the UHC. I think there has been attempts to sort of solve this problem. And for me, from where I come from, with the political will that has been demonstrated with the UHC role, I think it is also our work as healthcare workers to sort of look at what is it that works for us. Of course, there is what the Constitution says, then there is in terms of devolution, but then there is also what is practical as far as services are concerned. And I think it is important. Right now, there is, of course, a healthcare workers conference that is still going on. I believe my friend Davji is there, but they are just looking at the curriculum. But there is need for us healthcare workers to draw back and to really look at what would be in the best interest of the patients and then reorganize there. And it is true that there have been some delays as far as flow of funds are concerned from the national government to county governments. And those delays affect salaries, those delays affect the manner in which counties can support healthcare workers. In Nairobi, for example, we increased the number of healthcare workers by 33%. We had only 3,300 healthcare workers. Now we have 5,100. And we employed more than 2,000 healthcare workers. But that does something that is also important to discuss, the wage bill, because our wage bill jumped from 35% to 58% of the budget. Now, in terms of sustainability of the services, this is something that healthcare workers cannot ignore, because you must create the space, and they must be part and parcel of that. So if we employ 200 doctors, there has to be commensurate output in terms of the services. Of course, for us, we can talk about the output in terms of the number of patients have increased from 1 million to 4 million. But in terms of the quality of the care, that there should also be an output there. In terms of the revenue, there should also be an output, because I mentioned that healthcare is not free. It's funded. So it's funded from the tax, or it's funded from the patient. So if the patient, we've already bought for them NHIF because they cannot afford, this money must come back to the facilities, because that's the only way that you're making it sustainable. Okay. And for us, we looked at those 4 aspects. We looked at the issue of access in terms of the real facility, the issue of access in terms of equipment, the issue of access in terms of healthcare workers, and then we are looking at now the policy framework that is going to make the services sustainable. Okay. And that is important. So I think in a nutshell, I'll summarize that it is possible for us to achieve UHC, but we must all be committed, and we must all not just be committed in terms of the words, but our actions must speak. And that action is not just a political action, it's not just a management action from Ministry of Health, it's not just the county government. I think the healthcare workers, we, and I am in this group, we must also go back to the drawing board. And that's partly why when I was requested to join Nairobi Metropolitan Services from the union, I did so, because then you must also be part and parcel of making the change that you speak about.
All right, Davji, and now you can hear your predecessor. Before he used to speak your language, now he has a different version of these events and he has the numbers that go with it. Do you agree with most of the things that Ouma Oluga is talking about?
Thank you, Trevor. I actually agree with some of the things that he's talking about, and especially in terms of the aspect of the human resource. I think based on what he has done in NMS, it was a clear show that there was a gap in terms of the management. And that's why you realize that he was there for a year, and with that period, there was an increase, first of all, in the number of the staff, that is the number of human healthcare workers that will actually ensure that there's service provision. But to realize that is different in all the other 47 counties. And in our tabulation, in terms of the workers that have been employed in the last 2 years, which was only, I think, NMS that had the highest number of workers employed. So basically, that will make is making NMS things to work. But if you look at it, it's not working in the different sector, in the different counties or different parts of the country. So that's a reality. The other thing is on the financing. It is clear that if the counties and even the government does not prioritize healthcare by putting more funds to it and investing deeper into it, we won't be able to have the health services that we need. So that is also something that we need to check at. And ideally, from what you have said, NMS is directly from the Office of the President, which then makes things to be able to operate. So if we then do not have the 47 county governments and make healthcare to be a centralized service provision, then whatever's happening in NMS is possible to be achieved elsewhere.
Okay.
Trevor?
Yes. Dr. Nikal? The Oluga says now it's time for the doctors to go back to the drawing board. Is that where it begins? And Datela is saying that now the difference is he has support from the national government.
You know, all this, they are all my... let me say they took over from me because when I was chair of KMA, I was doing both the union work.
We are only students.
And the welfare work.
They're only your students.
But... we were on affordability, but let me go back on the issue of the health workers themselves.
Yes.
It is true, as health workers, we must also take the responsibility. Whatever people may say, the health workers are actually the leaders in the service provision. Because whatever else you put in place, if they don't work or if they don't manage it, people sometimes think they don't have to manage it, somebody else can, but that doesn't work. So we must also come in and give the commitment that is required. This actually becomes a problem at higher levels where it is possible for the doctors, for example, to be both in government and in private practice. And then the distribution of the time, where do you put more time? That becomes a problem. We must be committed that for what we are paid, we provide that. The other one is just the human element, that when you are looking after sick people, as a professional, you actually have more responsibilities than all other people behind you. That is why if there's a failure at the hospital level or at the bed level where the patient is, they see the health worker. They don't see Even for the cost of care, they see the health worker. They don't see all the other people that are behind the health industry that eventually terminates in the health worker and the patient being together. So we have that responsibility. And it's not that Luga is now on this side. I faced the same problem when I became DMS from being a chair of Kenya Medical Association. But we agreed with my colleagues. We work for the welfare of health workers because they provide an important service to people. In fact, their value is in what our value as health workers is in how we take care of the people. We lose that, we lose the respect that people give us and even the expectation of the society. So he's right on that. But coming back to affordability, you see, it is the cost of care. Health care is not, it cannot be free. It is just who is paying for it.
That's true.
Either the patient pays out of pocket, and that is what impoverishes everybody. Trevor, there is nobody who can afford health care. Even the most well-paid people, even with the richest people, if they have serious illness, if they didn't have insurance, they would literally be wiped out. So either the patient pays, or the government pays, or you go through insurance. Those are three. In all cases, there is the issue of the cost of care. Affordability seems to imply whether you can access it with the resources you have. But the bigger thing is the cost of care. And I think that is what we must look at in the country. In the public facilities, the cost of care is not seen so much as you see it in the private sector, but it's basically the same thing. So what are the costs of care? What are the drivers of the cost of care? Let's take the private sector. It gives us a better example. We can extrapolate it to the government. First of all, it is the cost of the health workers. If they are in private service, it is the consultations, the cost of the services they give, like the surgeries and so on, relating to the person who is doing it. In the public sector, it actually comes out as a salary that is paid to that person. So it is still a cost. But in the private sector, there's a consultation you pay, there is a service you pay for, procedures you pay for. So those procedures are a big cost of care. The other cost of care, if you are admitted, is actually the cost of the hospital, which would come out as what you pay as a hospital, the hospital bill you pay to the hospital. The other one are the inputs. And what are the inputs? The drugs come out first, but there are a lot of other inputs. So as a country, we need to look at the cost of this. And it will also come to standardization. For surgery, what should be the cost of surgery? What do you pay? And it is possible to sit down with the doctors and the people who are paying for health services, the consumers, and agree that for a cesarean section, this is what we should pay. Across board. Across board. And we'll work it out from its cost, which affects even the public facilities. And for this surgery, it is this. Then you will say, if you sleep in a hospital, even before you are treated, you know, a hospital is first of all a hotel. So if you sleep there, what is the cost of that? Then there'll be the nursing that you will get. What is the cost of that? 3, what then is the cost of the inputs, the drugs in particular, and this? We can sit down and actually say, from the market where we buy all these things, because we don't get them, this is the cost. And the doctors can say, we will charge this much and agree on it. And we have an arrangement, an institution. It can be by law, like in other countries. Every year, that is reviewed. Then what the hospitals charge, the hospital can sit down with the government, with the consumers, and say, for this type of hospital, what is the bed charge? The bed charge, unfortunately, will have some elements which are not health related. You may want to go to a place where you want a TV in your room. That we can take out. Then drugs, we can say, because drugs is an area where we can make a huge cost saving. Reduction. Because when we talk of generics, People think generics are inferior drugs. They are not.
Yeah.
It is just that the original molecule was invented or formulated by somebody, and therefore they tend to be very expensive. People copy them, and some are copied perfectly. I know a drug that I've used before, that the original is about 75 to 100 shillings a tablet. And there is a generic that is costing 5 to 10. And I can tell you, it works. So we can then have a formulary. What do we use in our facilities as a country? And we can agree. And we can have a body that reviews that every year. So when you do that, you reduce the cost of care. And that is required even if you are on insurance, even if people are paying individually, even if the government is paying. So that is another area we need to look at to address the problem of affordability.
All right. And Dr. Luga, what would it take to achieve what Dr. Nyikal said? Because those are brilliant ideas.
I think Dr. Nyikal and I, we belong